Preeclampsia and eclampsia, I'm sure you know very well. I don't have to tell you about this. But essentially, if you have hypertension, proteinuria, and if they have obviously any seizures or coma, we call it eclampsia. But of course, you also see abnormal LFTs in this as a part of the multi-organ failure in preeclampsia conditions. So yeah, preeclampsia is generally seen in people who are nulliparity and also with extremes of maternal age. And if they are small size mothers, they are risk of developing this issues. And obviously, as I mentioned here, transaminases can be elevated with bilirubin being elevated as well. But most often we see that with the HELLP syndrome. So HELLP, as the name says, diagnostic criteria, you should have hemolysis, you should have elevated liver enzymes, and also low platelets. So that's the diagnosis of HELLP syndrome. Thankfully, it is not that common, but it can be a deadly disease. And I think Dr. Ganesh has already mentioned about the hemolysis. The important factor is the LDH. And the primary pathology that you see in HELLP syndrome is the microangiopathy. If you actually do a biopsy of these patients, you have a lot of thrombotic events to the microvascular areas, particularly in the liver and other organs as well. So common presentation is non-specific upper abdominal pain, nausea, vomiting, headaches, and also hypertension, proteinuria, because this is a consequence of the preeclampsia that we generally see. Less common is the AKI. Late findings, of course, as the disease progresses, you have risk of DIC, pulmonary edema, placental abruption, retinal detachment, and also intrahepatic hemorrhages are also very common. So generally, as I said earlier, it is generally seen in 27 to 36 weeks of gestation, and HELLP is common, as I said, in multiparous and older patients. And the main pathology is basically vascular endothelial damage with formation of the prothrombotic conditions in it, and that's why you see this episodes of multi-organ failure. Management essentially is delivery of the baby. If the baby is more than 34 weeks and there is evidence of multi-organ failure, then there is no question immediate delivery should be affected. If the fetus is less than 34 weeks and the HELLP syndrome is mild, then you can consider giving dexamethasone for 48 hours before the delivery. But again, it has to be a judgmental call based on how the patient is behaving. If the patient is well established, labor should be allowed to proceed in the absence of any obstetric complications or DIC. But many patients may require cesarean section in these patients. Maternal mortality, thankfully, these days is very low, about 1%. But perinatal mortality can range up to 7 to 22%. Liver transplantation is very, very rarely needed. The more important dreadful complication with the HELLP syndrome is the hepatic hemorrhages, which can rupture, and therefore very careful monitoring is very much important. If there is any signs of rupture or rapid expansion of hematoma, then you should be going for interventions, either radiological interventions or with surgical interventions. If they do have hepatic rupture, the mortality is almost up to 50%. So therefore, it's very high index of suspicion that we should keep these patients in with HELLP syndrome. Budd-Chiari syndrome can also occur with HELLP syndrome, another condition which is commonly seen in pregnancy. Recurrent rates are also high. Therefore, it's very important that you counsel your patients for any kind of HELLP syndrome, especially if they have any preeclampsia, prematurity, or abruptio placenta. They have very high risk of developing HELLP syndrome. AFLP is one of the dreadful diseases that we see in pregnancy. They almost behave like an acute liver failure in patients, which is a very sudden and catastrophic illness with hepatic failure manifested as coagulopathy and hepatic encephalopathy in a pregnant woman without having any previous pre-existing liver diseases in about third trimester of pregnancy. The thankful incidence is not so common, but again, as I said, the mortality rates are very high in these patients. And AFLP is more common in nulliparous women. So presentation is a typical presentation. You see patients with non-specific symptoms of anorexia, nausea, headache, vomiting, and then right quadrant pain. Then they suddenly start developing jaundice. Then they start developing encephalopathy. Once it's developed jaundice and encephalopathy, that means this patient has ended up in having acute liver failure and very high mortality for these patients. So it's very important that you start delivering these patients as soon as you see the AFLP. AFLP can also present after the delivery of the baby as well. So you have to have a high index of suspicion for these patients. Generally what we see is mild elevation of the transaminases, but bilirubin will be high. More worrying thing is the hypoglycemia. So any patient with AFLP, if you see hypoglycemia and confusion status and coagulopathy, along with metabolic acidosis and renal dysfunction, that means this patient is heading towards the death's door. So it's important that we deliver these patients as soon as possible. Rarely we do liver biopsies for these patients, but if you do a liver biopsy, this is how you're going to see microvesicular fatty infiltration. Basically what happens is the fetal the long chain hydroxy dehydrogenase, when there's a deficiency to it, the fatty acids they actually go through the placenta into the baby. When the fetus does not have a deficiency of this enzyme, it produces more fatty acids which get replaced back into the maternal system, and if the mother is having heterogeneity of the LCHAT deficiencies, you have more accumulation of the fatty acids, which can be a toxic metabolite, which results in the acute liver injury and acute liver failure. So there's a study which looked at with the kids who are actually having a fetal LCHAT deficiency. 20% of the mothers ended up having AFLP, and that's why it's important that any baby who's has been delivered after AFLP should be checked for fetal LCHAT so that we can warn the mother for the further pregnancies. Management, as I said earlier, is delivery of the fetus, and then very rarely we do require transplantation for these patients, and essentially it's managing the patients in a conservative management. Prognosis, and if the patient is delivered at an earlier stage and have a good prognosis, but recovery can sometimes be delayed for months, but incomplete with no signs of any chronic liver disease. With good management, good support treatment, delivery and the mortalities have reduced significantly. This is just a summary slide which shows that these are the 4 different conditions which are unique to pregnancy: intrahepatic cholestasis of pregnancy, hyperemesis gravidarum, preeclampsia, eclampsia, HELLP, and AFLP. Important things to note here is the mortality rates are significantly high with these 3 conditions: the HELLP, AFLP, and the preeclampsia. All of them need delivery promptly. IHCP can be managed conservatively, and fetal mortality is less, but maternal mortality is almost 0 in IHCP.